Thank you very much for coming to our Innovative Discoveries Seminar, which is sponsored by the CTR and the Value Institute. We are very, very happy and very lucky to have today Dr. Rosenthal, who is from Christiana, who is the chair of the Department of Family and Community Medicine here. He's also professor in the Department of Family and Community Medicine at Jefferson Medical College. And he is the director of the community engagement component, community engagement and outreach component, always, which is known as CEO of the ACCEL Delaware CTR, our ACCEL CTR program here. So prior to coming to Christiana, Mike was vice chair of the academic program and research in the Department of Family and Community Medicine. He belongs to multiple committees and chairing councils, and right now he's the chair of a health advisory council with the state of Delaware. Very active with the Society of Teachers of Family Medicine, chair of various committees and multiple times. Dr. Rosenthal has had multiple awards for excellence in teaching and also awards for health promotion, and has been PI and co-PI on multiple grants. So we are very happy to welcome Dr. Rosenthal here for giving us a talk. Thank you so much, Mike, for coming.
Oh, it's my pleasure. Hello, everyone, and thank you, Claudine. And I believe that's the most lovely French introduction I've ever had.
I'm making a big effort.
I think it was great. I'm just sitting there. I just wanted to listen to you. I didn't want to. I'm speaking like I speak. But hello, everyone. Thanks for everyone in the room. And I know there may be some people listening in or watching from other places, and so welcome also to you. It's my delight to be here today and representing the ACCEL program as well as other things that I've done. And this is a bit of a historical and to the moment view of I think some very important things that we need to consider on the horizon. And I'm going to start off with the first slide and say we're going to think differently perhaps than we've been thinking before, and I'm going to ask everyone to think macro on this, bigger, open. And a lot of times when we think about research, we think about coming down, getting to a point, but this is how to think broad and across and out. And so it's a kind of a flip, and maybe we'll talk about that when we get to the discussion, but I want to be prepared for that because I want everyone to think about, and I'll give you the bottom line first, and then follow it through. We often think of an intervention in clinical care if you have people that have pneumonia and you give an antibiotic and they get better. That's an intervention. If you have two different drugs in control, you say which drug's better and which drug is not working. You call that comparative effectiveness. And you have an intervention and you follow a clinical course. Or if you're in a chemistry lab and you have two substances that aren't working together and you give them a catalyst and all of a sudden they make the chemical reaction go forward. Right? I want to propose, and we'll work through this a little bit, that a community coalition is an intervention of a different kind across the community and or across health systems that can provide change and go from point A to point B, whatever the point A to point B is, whether it's a catalyst causing a reaction or whether it's an intervention changing the course of something that comes out with a different and perhaps desired outcome on the other side. And the coalition is the intervention itself. I'm going to give that first. And then there's a lot of details to that, but I've had the good fortune of being involved with a few programs that we'll describe in detail over the course of the last 15 years or so, perhaps a little bit longer, but about 15 years. And what I think it means to what we're doing now and how it wraps into some of the things I think we need to do in terms of ACCEL and thinking forward. The other thing I'll say at the beginning is in work I'm representing, there are literally hundreds of people that have been involved across many communities across the country in Puerto Rico that have been part of this. And there have been people that have thought, when we present the research on this, of probably about 60 to 80, 90 that were involved in collaborating on the research that I'm presenting, and I'll comment on that as we go through. And I do it, thank you for the note of my interest in education. I do this because it's my role as an educator, and it's kind of why I like the community engagement outreach piece, because it does tie the education to the care and what we need to think about. So that's the big introduction. Now, we're going to step back and step forward. Okay. It's a little bit hard to see, but that would be me. 1977, a short 38 years ago, working in Franklin, Louisiana, there's 77, with 5 community health workers end of first-year medical school student, end of first-year medical school student, end of second-year medical school student. On a project from the AMSA Foundation, going to a clinic in rural Louisiana, Franklin, about 150 miles west of New Orleans, and working with a federally qualified health center now. It wasn't even called a federally qualified health center then, it was called the Touch Action Clinic. And we were fortunate enough to identify some funds for paying folks that could do community education. As part of our summer, we found a grant mechanism. There was grant to give, so we were able to identify 5 different people from 5 communities around Franklin, Louisiana, and work with them to do issues of how do you take care of your blood pressure, how do you take care of diabetes, what's good nutrition, what about exercise, 38 years ago. So we think that's new, right? What goes around comes around. So this stimulated my interest in some of the topics that we're talking about today, and will also relate to some of the things that we looked at with asthma, and relates to some of the things we would need to think about for ACCEL. So I started there, not as much for me, but because of the historical reference that this stuff has been out there, but how do you study it, how do you think about it, and what should we be doing, but also the piece that was mentioned for those that were at the ACCEL conference on Jim Mold. If you're out there doing it, it helps give you a perspective, and so we're going to get to that word perspective, a perspective of what you're doing to understand how to apply things in the real world. And so that's where that applies to our coalition theory stuff. Working with machinery. Oh, it worked. So broad-based perspective of the country, really fast. But I'm going to give a lot of references because it's too much to cover to say everything about everything, but I think this is a research symposium, and therefore we want to give references to people they can go find a lot more information on their own. So in 2012, the Institute of Medicine report, Primary Care and Public Health, Exploring Integration to Improve Population Health. Well, I talked about population health. Institute of Medicine said we've got to figure out how to put these things together, integrate what we do in practice and what we do in care. There's another one called the Folsom Group, which is Folsom Group Revisited, based on studies done in 1969, 8, 7, somewhere around there, late 60s, that described the need to develop communities of solution to address difficult health problems. And the reason this was revisited in 2012, because the Institute of Medicine report and other people around the country are thinking about how do we think about developing communities of solution to address health problems. Really important. Something came out last year, just a year ago in 2014, I was actually at the announcement for this. It was very nice. A practical playbook from the CDC and a colleague at Duke University and the Beaumont Foundation, a playbook about how to put public health and primary care together. It relates back to the Institute of Medicine report, and there's a follow-up to this about how do you think about and study something, and how do we really start to work together in our communities. And you can go right to the CDC website because they're picking up on it too, as are many other national leading organizations, about what to do in primary care, public health, and actually tying to the health system. It becomes really important. So the CDC says strong linkages across healthcare and public health are vital to addressing national health priorities at a systemic level. Health reform changes make strong collaborations among clinicians and organizations in these fields even more pressing. Strong collaborations among clinicians and organizations in the fields of public health. Okay? So we've got to think about putting those together. Therefore, this is something I've actually been showing for a good while. This integration, we talk about in the 80s, 90s, you could identify traditional medicine would be my left hand and public health would be my right hand, and nobody was tying them together. And there would start to be a blending. My view is community health is, number one, not the same as population health. I won't get into the semantics now, but we take care of populations of people that may be in a community. But the definition I'm using for today is how to affect the health of a community by providing care in its broadest sense in the community, or access to care, or involvement in care in the broadest sense in that community, by combining some aspects of traditional medicine, so it can be primary care, but it can also be health system, and combining it with public health methods. So community health to me isn't exactly the same as public health, right? Because public health has more developed on the side of the things that are done outside of the medical offices. This is the blend. Now, on both sides, in the traditional primary care and health systems, we're starting to do more public health, good. And in public health side, people are starting to think about how do you do the medical care, also good. It comes together often in the community, and that's what this is about. How do you focus that for, depending what the community is. It could be a community of providers in a health system, like this one. But we still need to think about the community that we're providing care for, or it could be in a local community, or a broad community. Translational research, I think, has been talked about enough here. So just to say, The goal is to translate findings from research into practice and meaningful health outcomes. And then there's another piece to that, right? To learn about what's out there, to build the research, to put it into practice, provide meaningful health outcomes. So this is from our colleague at Jefferson and friend Scott Waldman, and it's a continuum of clinical and translational science. Okay? So a lot of people have looked at these kinds of things, and a continuum T0, what's happening in the lab, T1 in people, T2 clinical trials, T3, T4 gets into dissemination and community engagement and health services research and comparative effectiveness, and T4, public health and prevention and population health impact and behavioral modifications and lifestyle modifications. So if we say that this is more practice and this is more public health, then here's community health. And here's actually a lot of the work we're looking to do in community engagement for ACCEL. The T3, T4, it's actually a blend. All this stuff of how do you work with the public health system or the state or the community and think about issues of prevention and behavioral modification and lifestyle modifications, because as we'll go through, if you don't do that stuff, you might have trouble affecting chronic disease, and in this case, the example for today would be asthma, childhood asthma. So ACCEL community engagement, I'm putting the specific aims up there just because it's important to do that and to remind us of why we're here. New infrastructure to involve the community in setting priorities, community institution partnerships in clinical and translational science, and educate community leaders, healthcare providers, institutional trainees, researchers, and scholars in principles and practice of community-engaged, community-based participatory research. The focus for today's talk, the coalition work that I'm talking about, did these aims. And I think that's really important, and we can apply these similar things. Now, this isn't all of what ACCEL should be about, but for the end of the discussion, we'll get to, I think, at least some of what ACCEL should be about. And it doesn't have to be coalition work, but it's the idea of tying public health together, involving a lot of people, getting community and provider input, and helping everybody understand from our broad definition of a research community, how do we want to think about these particular problems, whichever problem we define. All right? Now, who's interested in these things? I put this at the bottom, a few of the people. The NIH, PCORI, the CDC, HRSA, Centers for Medicaid, Medicare, state foundations, etc. A lot of funders are interested in this. They read the Institute of Medicine report also. So as we develop research, as we think about translational research, we want to think about these things. People have seen this slide before. If you haven't seen it, welcome. I will keep showing it because I think it's going to get a long time to get it right. There's a balance that's out there, and I'd say a dynamic balance. And it really is a bit of a teeter-totter. How much community and provider involvement, how much research involvement, how do we think about the different perspectives that get balanced. I'm starting to name these children T2, T3, and T4 research, and these children's provider and community and broad community state. And the balancing of these types of things across the different areas that we want to work in. PCORI says, so this is off the PCORI website, we help make people make informed healthcare decisions and improve healthcare delivery and outcomes by producing and promoting high integrity, here we go, evidence-based innovations that comes from research guided by patients, caregivers, and the broader healthcare community. When we're talking about the broader healthcare community, they're not talking about where I am standing right now, Christiana Care Health System. They're talking about the agencies, the folks out there, people themselves. How do we really understand the guidance to what we need to do to help people in their lives? And I think that that's a big switch than some of us are used to, but that's okay. That's where things are going and a lot of discussions. So where to go forward? I started with engagement. Why did I start with engagement? As I'm talking here, I hope to engage you. Right? And so we're about community engagement. I'll put that in quotes. Well, I can engage you, and you can pay no attention. I can engage you for a while, you can drift off, and I can give you nothing in terms of this talk today, and you can learn nothing. You go out of here and you were engaged for a while, and then you tuned out, and then it didn't change anything. Right? My goal here is to go beyond engagement. So when we talk about community engagement, it's only a starting point. Only a starting point. So we have to go from engagement to including people. That builds relevance, and this was brought up by Jim Wolf at the ACCEL meeting, so I put it up there because I think there's relevance to what's going on. If we engage more people and have relevance, we'll build perspective about what we're doing and be able to create collaborations and partnerships that will enhance the quality of the work we do and reach more people so that we can have better health outcomes that will impact the health across our broader community. If we do that, will get to success. Said a lot, that's why I put it in that order. And there's a lot to do. That's okay. We're at a really good starting point. I like to think that we've already made good progress, but we've got miles to go, and that's okay. Why childhood asthma? For those that are clinicians in the audience, I'll do a quick review. For those that are not clinicians, I'll do a quick review. Burden of disease. You may not know it, but the prevalence of asthma has been steadily increasing from 1980s, 90s through now. The last data we have from the CDC is back in 2013. It's at historically high levels. That would be the prevalence, and the incidences that have been going up steadily for the last 25 years or so. And that there are disparities in care and they abound. And so if you take the national average rate of asthma in children, it's somewhere around 9%. But you can go to some neighborhoods in Philadelphia, and we've done some of this work, or New York, or Chicago, and you can find asthma prevalences in children of 20 to 25% or even higher in targeted neighborhoods. Understand that. What does that mean? That means if you go to a classroom of 25 children, 5 or 6 will have childhood asthma. And if the rates are not, if asthma is not well controlled, assume that 2 or 3 of those children out of the 5 or 6 won't have well controlled asthma, and then assume that that will make them more absent from school, less able to learn, less able to exercise, more likely to have problems because they don't exercise, require their parent to pay attention, have income issues on their parents, have them miss work days. A lot, right? So we need to think about it like that. So, and there are disparities in care also that, we know that it's higher in African American children and white children, more in cities than rural places. Childhood asthma, we also know that the death rate for African American boys over white boys in childhood asthma, the deaths to childhood asthma are rare, it's about 5 to 6 times as much. Okay, so fortunately the deaths are rare, but it's also a marker of the morbidity in those populations. So we got to think about it like that. We already talked about the quality of life issues. I'm not going to spend too much time on this because I want to make sure we get through the talk and have time for discussions. But you're hearing about if asthma is not well controlled, people use the health system a lot, ED and hospitalizations, it affects them personally and their family. Internal factors, I should have also written personal factors. What I meant is things that are internal to the personal situation that as providers we would say affect our lack of control and challenges. What's the adherence to medication? Where are people and are they coming in? How much do they understand about what they're doing? How well are they doing on self-care? And something that I often say, and I think it applies here, we have put a lot of the burden on the care of illness, especially chronic disease, on the provider, and to some degree, the primary care provider. Why isn't this person's asthma controlled? Okay, here we go. I've got a really good follow-up of every 2 months of a child and his mother or father, or her mother and father, 6 times in a year. And I see them for 20 minutes at a time. And I do really good work with them. How much time is that? 2 hours in a whole year. What are they doing the other 364 days, 22 hours of their lives? And how does that apply? And why does that relate to childhood asthma? So hold that for a minute. You have those internal factors of who the person is, their genetics, their background, how they take care of themselves or not, and then external factors in the environment, home, school, community, environmental toxins, tobacco, all these things that we'll talk a little bit about what triggers asthma. Well, if all those things are happening outside of the person and they're not taken care of, how effective am I going to be as that provider that sees the child for 2 hours a year? And what's my ability to manage their asthma, really, or help them manage their asthma, more importantly, if I'm in my practice and doing that? So one of the reasons to think differently in the integration that we're talking about care and public health in the community. So here's a quick summary of Childhood Asthma Coalition Activities and a timeline, because I wanted to bring the broad picture of the timeline that we're talking about and where my involvement comes in and the projects that we'll be talking about. So in the 1990s, actually I'll go back a little bit earlier, in the late 80s, there was the identification that we were doing it wrong in practice. We were using controller medications, often known as beta agonists, for taking care of asthma. And in the late 80s, it was identified that asthma was an inflammatory disease, and it needed to be treated with anti-inflammatory medicines primarily, not wait to treat with anti-inflammatory medicines. That's 25 or so years ago. And it flipped how we were doing asthma care in practice. It also led to the National Asthma Education Program from National Institutes of Health, NHLBI, in 1989. So just 25 or so years ago, the National Asthma Education Project started happening. Early 90s, there was something called, and we'll refer to this a few times, the National Cooperative Intercity Asthma Study, NICAS, which took NIH approaches in communities and in practices in homes about how to study triggers for asthma and how to hopefully ameliorate them. And that has been used as background because that happened in the early 90s. The papers were written in the mid to late 90s, somewhere around 97 to 99. And then here we have Robert Wood Johnson Allies Against Asthma announcement, which said we've really got to start thinking about asthma differently. So that's why the historical reference. I was involved here. Actually, I had an interest in asthma. I was teaching medical students about asthma in the late 80s, about the change that I was just talking about the change in care. So I was following the asthma education program. There were also some task forces in Philadelphia, smaller, not well organized. Philadelphia Asthma Task Force, and there was another Asthma Coalition and Philadelphia Asthma Coalition, I think. And another group called Mid-Atlantic Regional Asthma Initiative, which was out of the EPA Region 3 and DHHS Region 3 in Philadelphia. And so we actually had a small grant to study asthma in homes and environmental issues in asthma in the late 90s for about a year that came, I think, through the EPA, maybe the CDC. I'm sorry, I'm forgetting that for a moment. No, the EPA, through the EPA. So that was background for things going on. When this announcement came out, Philadelphia was fortunately one of 7 communities out of about 253, I think was the number, that was able to successfully get the National Allies Against Asthma Foundation grant, and followed that through to 2005. There was a little bit of bridge time here to finish up the first round of allies, and then Philadelphia also was one of 5 communities out of about 168 to get a Merck Foundation, Merck Childhood Asthma Network grant. So right about here, I became involved. Actually, I was involved in these things here as it was building in part of in the grant development. And here, I became co-chair of Philadelphia Allies Against Asthma. That'll be discussed here. And Philadelphia Allies Against Asthma was one of the component programs that did both the Robert Wood Johnson Foundation Allies Against Asthma and the Merck Foundation Childhood Asthma Network. I came down here in 2010. There was an NCAN2 project, which is a little different, and is still running, and we'll talk about that a little bit as we go through the slides. But what we're talking about today is this period of time, actually from 2000 through 2010, and then some follow-up data after it. So Allies Against Asthma. National Initiative to Improve Asthma Control for Children and Adolescents, funded by Robert Wood Johnson. And it was first the National Program Office at the University of Michigan School of Public Health, and the Dean of Public Health. I'll mention just a few names out of those hundreds that were involved, but Noreen Clark unfortunately died about a year and a half ago. A great colleague, friend, and mentor, was really a lot of the brainchild behind a lot of this work that I'm presenting today. And she was initially the Dean of the Center for Managing Chronic Disease at the University of Michigan, and she was the Dean of the School of Public Health, and then she started the Center for Managing Chronic Disease at the University of Michigan. And so it transitioned over to that. In addition, this project was looked at. Remember I was talking about the NICAS study? Well, there was assistance by an evaluation group called Battelle. Robert Wood Johnson was involved. There was a National Advisory Committee, which had people from the CDC, the EPA, the NIH, experts on asthma, community health coalitions, and community-based participatory research. So I had the good fortune of working across these groups. And I'll just say quickly that the 7 coalitions that worked together worked with all of these folks as one large research committee. It was a wonderful, wonderful opportunity for all the people involved, including me, to learn from each other. And I think that was really neat. As a lot of this talk was going on, we were learning from the CDC, the NIH, and the EPA, and they, I think, were learning from us, what we were doing across our communities, what we were bringing in, what we were seeing across different communities. And the communities were learning from each other about what different people were experiencing. So that perspective thing that I'm talking about, and why it relates to community engagement so much, how much we can learn if we're in touch with what's going on in the practical world, is invaluable in helping us design and understand research. So the project aims for Allies Against Asthma were 2. Can you build a coalition for system change And can you, health system change, I should say, and can you impact the burden of childhood asthma in those communities? And then, of course, from the research side, can we measure that and show outcomes? Okay, so those, I added the third because that was clearly an aim. But the project aims, can you do this, build a coalition, can you impact the burden of asthma, and can you measure it, is the third, and show it. Funded communities, Washington, Kings County, which is basically Seattle, Milwaukee, Puerto Rico would be San Juan, Long Beach, California, Hampton Roads, Virginia, which is near Norfolk, and Philadelphia, Pennsylvania. Here we go. So I'm going to hold up a few things. This is the further talk. Visual aids. That's this. So if you want to learn more about this in the Robert Wood Johnson Allies Project, you get to go to Health Promotion and Practice from April 2006. It's a supplement of what happened across the coalitions. Way too much for me to present today. So I'm doing a summary overview of the research related to the projects that we're talking about to see that third point. Okay, what was the coalition formation? How did you impact childhood asthma? And what were the outcomes? So I'm referring you and giving you references for the outcomes because I can't talk about it all today. There's way too much, but that's a good thing. So this talks about, in the first one, a lot of the theory behind the background of the development of the Coalition for Allies Against Asthma and a case study in a model of how this theory would play forward. It didn't have a whole lot of results. The results on this were mostly about the formation of the coalitions, and that was studied by Bechtel, who did qualitative analysis. The rest of the outcome studies were more by the National Program Office at the University of Michigan that we all worked with. This is from the first article, and it was headed by Noreen, and I know it's not good to see, and that's fine for now. The point is that if you look here, you have more appropriate health care use, improved health status, and enhanced quality of life. Appropriate health care use, you could say cost, and here you could say improved outcomes and quality and perhaps experience. You say basically I have a triple aim, right? That's what people are looking for. And here, the biggest important little words out here, this took us about a day, 6 to 8 hours in one group of people in the room to map this out, and then it became part of this article. Community context, and it's got all the things that go to community context, and the pieces of developing a coalition and building to these outcomes. So it was actually more a theory than the outcomes proven at this time it was proposed. But that was the theory that we were working on. And again, that community health piece, the community context and all the input from folks working with respective conveners that can pull this together to organize for what we're going to do in each of our communities to impact asthma. It wasn't the same intervention across all communities. Really important. Okay, we had the same goal, but the intervention was the coalition. That's why I started that. The intervention was the coalition itself, and then put the coalition to work with whatever variables that coalition needed to deal with at the community level. Really important. So, to highlight a couple of the articles in the journal I just held up, Fran Butterfoss is a colleague at the University of Virginia. She's an expert nationally in coalition development, and she did the study about the formation and development of coalitions. You also see my name there. I got to work with Fran. I was the lead author on the next piece, the coalition process at work, building care coordination models through coalitions to control chronic disease. And so we combined these for some of the coalition theory that was put forward in the document I just held up. And one of the things that's there, these are the stages of coalition development. They have to form and get implemented and be maintained and institutionalized. And then they have to figure out their tasks. And part of that is how do they govern themselves and how do they make decisions, and then how do they get to integration and implementation. And then if it's for a health coalition, how do you integrate across the programs and the different things that are going on in your community and lead through to integrating systems and more effective service delivery and improved patient outcomes. Okay? And there needs to be a transformation period. It's not exactly a switch. It's actually a continuum and a dynamic process. But you have to build toward these things. It takes a little time. But everybody knows in the different coalitions, they didn't hit it at the same time, but there was this transformation period where they were able to make decisions as a coalition and where they were able to integrate the systems. Quick aside, what are we doing in population health at Christiana Care, and perhaps people listening from other places? We're trying to figure out how to integrate systems and produce more effective service delivery to improve patient outcomes. This is the whole thing about population health, right? We have all these things at the beginning, and we're not integrated, and we have individual programs and organizations in our own hospital and across our community, and we're saying, okay, how do we do this better? That's exactly where we're at. Okay? So it ties directly together with what we're doing in healthcare. This one also from the article that I did, which is integration happens both vertically, up and down through a health system, and horizontally. And so without going through all the details of the different things, but this is at a service or horizontal integration level, at what affects the patient and their family, who are the providers, who are the community-based organizations, who are the other people that are out there like home care agencies or nursing agencies or pharmacies, who's involved in the care of this child with their parents and this patient, okay? Who helps them in their lives at a community level, or who's involved in their care, but who's involved as a hospital system or a division of public health or a Medicare managed care organization or other health insurer, and what are the legislative policies in the government? Now, other quick aside, we have a great opportunity in Delaware because the state is interested through the state grant, right, about tying a lot of these things together. The state health innovation model is related to this. That's really good. Well, when you think about that way, because opportunities for ACCEL, how do we tie to what the state's doing? We may not be able to, or should we tie to everything, but we want to think about these things because there are enormous opportunities for evaluation and research related to what's going on, and we have to make them practical, focused, but there's a lot of opportunities to study a lot of what's going on. So quickly, Philadelphia Against Allies, as mentioned, formed from two existing smaller coalitions and the MRI activities of EPA and HHS. And 2000 to 2005 had 1 year of planning and 3 years of implementation. So it only had 3 years to get the job done, which frankly everybody said wasn't enough. And then the Allies Against Asthma also applied for an Irish co-PI with Tyra Bryan Stevens, who we'll talk about there's a CAP program in Philadelphia and part of the Merck Foundation. Philadelphia Allies, now part of coalition theory quickly is that people kind of come in and go out a little bit, but there needs to be an infrastructure and a governance structure. So it were more than 40 organizations and more than 110 stakeholders over that approximate 10-year period. And several health institutions, Philadelphia, an interesting landscape, but we won't go into that now. Community-based organizations. We had people from city, state departments of health and public health. We had government, U.S. government represented. We had insurers. We had a few media members. We had the neutral convener, and I'll acknowledge here that in addition to the asthma work I've done on the medical side, I was also the Vice President of Health Promotion Council, so that's representing my bias, but also involvement. That Health Promotion Council was seen and identified by multiple stakeholders across the community as the organization to provide the infrastructure and put in the grant. When the grant was funded, the HPC served as the neutral convener and the infrastructure for both the RWJ and Merck projects. Philadelphia Allies Against Allies, Activities, and Products. I'm going to just mention them quickly and then go through some highlights of what we found. Asthma Safe Kids was an education program that is based some on American Lung Association work, and it was a national imaging education curriculum, and it was provided by nursing collaborative centers in Philadelphia out of what was then Philadelphia Health Management Corporation. PACE, the National Education Program for Providers. Smokeless Homes was something that we developed as an education program about home and community settings. Community Asthma Prevention Program mentioned. It started as part of the Allies array of projects and then was co-partner with the Allies group for the Merck project. We'll get a little bit to that later. Open Airways, again from the ALA, Lung Association, all about asthma workshops for teaching programs that were done in families and community education. We developed a common asthma action plan from a provider standpoint. We were very interested in saying there's multiple managed care asthma organizations out there. Happen to work with us to work with providers to help define and build consistency about what we're doing. And then the Child Asthma Link Line, which we'll talk about in more detail now, that was the biggest focus for the Allies Against Asthma project in Philadelphia. So quickly, there were a care coordination or Child Asthma Link Line, which had two health educators / case management, social work type folks involved. One was African American, the other was bilingual English and Spanish from the Latino community. And this was not just a referral line. This was an incoming, tracking, and referral system in and out, and also served as part of the data gathering for the research that we did, so that it worked with managed care, and it referred people from EDs and schools and provider offices and community agencies in. It also referred for children who didn't have insurance out to get children insurance. So it was very helpful. We worked with the Asthma Bus for screening in our community, asthma education in community settings, schools and homes. I mentioned smokeless homes quickly, and in-home environmental assessments and providers, and we tied all these things together. All the time? No. Some of the time? Absolutely. A lot of times? Sometimes. But the more we could tie it together, the more we could link these things, that was the intention, the better off we felt we would do. So now a quick note on a link line study that we did that was published in the Journal of Asthma. So now the work was done on the link line from about 2001 through 2005, and this was a study of children. I just mentioned the link line initiative to get children in the link line, telephone-based care coordination by asthma coordinators, connect them to health services, and include tracking and follow-up. I'll do the highlights because of time. This was an interesting Medicaid managed care organization claims database. So I'm looking at Harvey, some claims data review and how do we put it together. We start talking about big data. We're going to have a couple of examples of that. And my emphasis here is how do you tie what you're doing in care to the big data or claims or however we're evaluating the outcomes below that. It's not just what's out there for claims and the trends we see in the claims. How do we involve what we're doing at a provider or community-based level in what we're doing and how do we track that to those claims? That's a little bit of where we have to go. So this had 59 children that received link line intervention for which we were able to match 236 children that did not receive the intervention out of a database of about 3,300 folks that were in the Medicaid Managed Care Organization's database. So it took working with managed care to do this, age 3 through 12, matched 2003, follow-up year 2004, outcome analysis of emergency department visits, hospitalizations, and office claims for follow-up. That's what we did.
There was a quick question.
Sure.
Can you just clarify, the link line was intended to just educate the family members or?
Tie them to services, provide education, links to care, and that's why we call it link line. Thanks for clarifying. Yeah. Really important piece. And follow up. Okay. Did you get there? Did you not get there? They didn't do what they did, 1 or 2, I think maximum of 3 follow-ups. They would make several calls if they didn't get through. So there were some people lost, but they would follow up. So this was not just a referral service. Really important point. Yeah, not just here's the number, go call it, we're done. It was part of the care coordination program. And that's the real important piece of this. Wherever the care coordination can happen, and we'll get to a little bit more of that, so thanks. Well, so the bottom line, basically, the intervention children less likely to have follow-up hospitalizations, more likely to attend outpatient office visits, and less likely to have emergency department visits from the link line intervention program. Successful. So it worked is what we're saying. And therefore, telephone-based care coordination and service integration may be a viable and economic way to impact childhood asthma and other chronic diseases was our summary conclusion. What's happening now in a lot of insurance companies? Who hears on their radio? We have a health coach, we have a navigator. Call us, we'll help you get through the system. This wasn't the only thing going on like this, but that's kind of why they're doing it. There's evidence out there that says if you connect people to the services they need and provide them that support, even if you don't see them in person, it just might help them access care better and get access to care better and involve themselves in care better and have people that can help them.
So how were these children referred to the link line? Because there were only 59 children, right?
No, actually over the course of, there were 59 children in the study. And I'm glossing over a little quick because of the volume of things. But there were, over the course of time, rough estimate, about 1,200 to 1,400 children in the link line. They came mostly from the emergency room, mostly from Children's in Philadelphia, some from Temple, but some from providers, some from community organizations that were working with us, some from word of mouth. You know, they got to us a lot of ways, but the predominant method was through the emergency department, which is actually what we wanted, because we wanted to impact the burden of chronic disease asthma. I mean, number one, you could argue obesity, chronic disease of childhood or life, but number one, other, in chronic disease of children, and to find the children, you wanted to find those most at risk. Where were they going? To the emergency room. So we worked closely with the emergency room to refer children in and have follow-up within 24 to 48 hours. And so we were really good about getting the follow-up and getting them in, and without all the details. So that was a key. The study, by the time we had to go through all the children that were possibly involved to find in the managed care database the 59 that we could match controls or match comparison group for. That's why we got down to 59. Next, this is longer term. So this is May of 2010, and we're out of Philadelphia now. We're across the cross-site evaluation that was done by the National Program Office with us working with the National Program Office for the different things we did across the coalition and figuring out where we needed to go with this research. So Policy and System Change Community Coalitions is actually a landmark article because it's the first one that said that a coalition, remember coalition put in the community what can it do, and then collect from cross-site from 7 sites, that this can have an effect. Okay? So 2 things. 1, policy and system change. Without all the details of the background, they surveyed people in the organizations that were doing the work, and they had comparison communities. This is going to apply in the next day, I point out also. They had comparison communities from across the country. They didn't include Puerto Rico because it was not easy to find comparison to San Juan, Puerto Rico. So the other 6 allies in the U.S. were compared with, I think it was 14, other communities that matched for relative size, socioeconomic status, racial makeup, and age. And so how they matched Philadelphia, I believe, to Baltimore. And they did other matched communities for the different allies cities. So they did surveys, baseline and follow-up, in the different communities that were comparison communities and in the allies communities. Actually, a great study design. I remember talking to Linda Jo Doctor at LJD in a restaurant in Philly and saying, "You're really going to do that?" She said, "Yeah, we'll do this." I said, "Wow." First time, I thought, we're going to pick up big cities and compare across, talk about big data. So, extensive tracking and documentation procedure. Oh, I'm not going to get into that, just for time. The findings: 89 policy and system changes were achieved, ranging from changes in inter-institutional, what happened in your own institution, and intra-institutional practices to statewide legislation, depending on the community. So a lot of policy and system change. Across all the communities, compared to the comparison communities, allies children experienced fewer daytime and nighttime asthma symptoms than comparison children. Okay, now is that an improved health outcome? It's a marker. Right? It's not an absolute health outcome. We think they're doing better in quality of life if that's true. We think they're going to the ED less. We think they're on control. Well, by marker of asthma disease, that is less control. But it's not everything. So that was early on. And in addition, there's a quality of life asthma study by Juniper that allies parents felt less helpless, frightened, and angry about their child's asthma than those in the comparison community. So that support for the parents, that whatever we're doing and whatever the coalitions are doing. And though this was interviews across the community, generally. Not an amazing study. So conclusions: community coalitions can successfully achieve asthma policy and system changes and improve health outcomes, and increase core and ongoing community stakeholder participation rather than was more important. I want to mention that it's how you get the stakeholders involved. It's not just having a zillion people in the room. It's getting the stakeholders involved was a marker for how much system change there. Asthma Coalition effects on vulnerable subgroups of children. Most frequent users of healthcare are the youngest. They went back, and this was, again, across the allies community, the same comparison communities, but this was Medicaid data. Beth Benedict, who's the second author, worked for Medicaid, and so she was a good colleague of Noreen, and they figured out how to get the Medicaid data and apply it across the asthma communities. And so in 2014, just last June, this was published about the allied zip codes being matched to the comparison zip codes or comparison cities, and they analyzed the data. Again, just going to the results quickly because of time, but in 2 years of startup, allies children were more at risk for having a significant effect. During the 3rd and 4th year, they were about the same for allies and comparison groups. But in the less frequent user, odds of an event were lower in the allies children, so they were about the third of having about the same significant effect, but lower in allies children. But among the youngest, the allies children had the greatest odds in comparison children of an event, but by the 4th year, they had lower odds. So the hazard ratios were studied for the youngest allies children and the most frequent baseline users of urgent care, and they end up lower in the allies group than for comparison children. What am I saying? I said a lot of things fast. Bottom line, the allies children, especially the youngest children, started out sicker. The allies intervention got them to about the same. And in the youngest subgroup, they got better from doing, the youngest children went from doing worse than the comparison children to better than the comparison children. That's the quick summary. Okay? So it's really a show that over the communities, the coalitions did impact asthma care and outcomes. So,
And it took some time also to get to that.
that's correct, and that's one of the things to say, you know, in terms of what do we do for shorter-term impact and longer-term impact, to be able to study that and analyze it. Now, with learning, we can maybe move that a little bit, but it does take time to really get into this data. What's the change? How do we monitor it? How does it have an effect? The changes, when you look at system change, don't happen overnight. We could put in an analyzed program, and it would take 2 or 3 or 4 years to run, and then go start collecting the data, or if you've started at baseline, designing the data as you should, you've still got to collect the outcome data, which may be a year or 2 after you've run the project for 3 years. So this takes time, and I'm glad you pointed that out. Merck Childhood Asthma Network, I'm going to breeze through a little quickly. Similar project, not exactly the same sites. Philadelphia and San Juan were the 2 sites that were left from allies, and the other 3 were Chicago, Los Angeles, New York. There was, again, a program office in Washington, evaluation support through RTI International and a National Advisory Committee. It changed in terms of what we did in Philadelphia and went more from a coalition, although the coalition was still active advising this, to a more of a contracted collaboration, because that was the grant. I was co-PI along with Kyra. So we coordinated the link line work with what Kyra was doing with the CAP program in Philadelphia and the community intervention. We tied in with partnerships with schools, with the Philadelphia Health Management Corporation and providers, and others were still at the table, but these were the individuals that were most involved, and also the city of Philadelphia. And we defined how to get people more to care and analyze what was doing across the community, so that there was a community intervention that used education and community health workers. The link line coordination stayed the same. We also worked closely with the schools about getting children either to the community intervention, dotted line there because it wasn't as strong, or to the asthma link line. And a lot of times we got them to the asthma link line, we would get them to the community intervention. We targeted high-risk neighborhoods, the ones I was talking about, with the 20 to 25% prevalence of childhood asthma, North Philly, West Philly predominantly, but also some other areas of the city. And we went around the city with different zip codes and targeted interventions sequentially to run this program. So quickly, a summary in time, because I want to leave some time for discussion. We had a summary article, and I give the references for that, so please look it up. Basically about the care coordination that improved asthma symptoms and led to a great improvement pre-post. We had some drop-off, and we can talk about that. We didn't have everybody in, but for those people that went through the program and had beginning and 12-month follow-up across all the coalitions, there was a decrease in absences and in hospitalizations, in improvement in controller use, an improvement in the action plan, reduction of triggers, and the bottom line, the coordination programs improved management behaviors and decreased morbidity across all sites. There was also in another follow-up document, so I'm not going to hold it up, but Health Promotion Practice also did the same thing that Allies did and gave a summary of all the Merck Childhood Asthma Network work, so you can look at that and just find the articles. The cross-site evaluation done by the Merck Childhood Asthma Network Initiative looked at how can we look at across our components. We did a lot of work defining the evidence-based interventions, which went back to the National Cooperative Intercity Asthma Study and documents from that, as well as some more recent things. We worked together as a group to define what questions we would use as common data elements across the different coalitions. So you're saying, how can we do this study across different coalitions in different places? And the answer is by defining the common data set of what we would look for. And so we had common things to evaluate, even if the interventions were different. So from a research design, you have to get to a common ground. Okay? But the interventions were somewhat different, but the goal was improving asthma. These were consistent measurements of whether the asthma was improved or not, based on evidence. Okay? And evidence-based interventions that, by the way, we were providing. And there's more discussion to be had about that, but not today. So the cross-site evaluation, I'll get to the conclusions. The evaluation, oops, let me go back one. Previous. A consistent pattern of improvement across all measured outcomes, including symptoms, hospital and emergency department use, school absences, and caregiver confidence. So children who start with uncontrolled asthma experience larger improvements than children with controlled asthma at baseline. and that was across all the asthma coalitions. Again, this is the overview for today. I do want to get to at least a few minutes of questions. Go ahead.
As far as for the allies study and the 7 different areas, was there, I imagine each of the areas had their own program design with different tools and different, initiatives in those areas. Was there any tools that kind of transcended all 7 of those areas and some that didn't work as well? Like, was there one that worked better?
It's a complex answer to a good question, which is every coalition was looking at different things, and just as we did in Philadelphia, other coalitions were measuring different things, and so there were a lot of different tools that were used, and there are a number of tools that were out there. But for the overall studies, the cross-site studies, there were common tools used. For the ones in Merck, it was mostly based on the NICA study that I mentioned. For the ones in the Allies program, it was more based on questions from the National Asthma Education Program and the Juniper Quality of Life study for parents of children with asthma, caregivers with asthma. So they were standardized more, but in each coalition, there were a lot of different measures that were used, and they weren't necessarily standardized.
Oh, okay.
People used their own tools, but people relied on common tools that were used.
Okay.
So summary for today. One previous. This important stuff, coalitions can work. We have to think about how to apply them. There's a lot of opportunity here in terms of all the things we're talking about in integrating systems. So it's not just coalitions, it's all the pieces of the coalition. So as we think about the system stuff, the big key here is tying it to the data and thinking about the evaluation from the beginning. But I think there's a lot of lessons to be learned in the coalition stuff that we've just talked about. The other thing for ACCEL, we know that Nemours is completing, our colleagues at Nemours, a childhood asthma program, and that will finish up by about June this year. And so I think there's a lot of opportunity to think about these things and issues forward from the provider and practice community. The MCAN2 that I mentioned isn't as much, it is community-based, but it's centering on some of the things we talk about. Navigators, how do we integrate, which is I think a lot of that public health, primary care stuff needs to go. How do we integrate what we do in the community with primary care practice and health system practice to really do effective population health in a community? Again, not the same thing, but in a community. And so how do we tie them together is really important. So that's what MCAN2 is looking at. It's got a lot of implications for how we look at things. And again, the State Plan and Innovation Grant about healthy neighborhoods and what's going on there and opportunities for ACCEL, and that's why it relates to our research agenda forward. And I did leave at least a couple of questions for minutes for a couple more comments. Sorry to run through the last bit a little fast, but enjoyed doing this today. Other thoughts, comments, questions?
Hi, this is the Wilmington campus.
Yes, we have a question for
We have a
Wilmington.
question.
Hi there.
Are these coalitions still in existence? And if so, do they retain the capability to gather information, data collection, and be able to act on that information currently?
Answer some yes and some no. And so remnants of the coalitions are still active in all the MCAN sites and in some of the Allies sites, but not all. And it's if you look at the coalition literature, some coalitions have a period of time. There's issues about sustainability and what's the infrastructure and grant funding and or other funding and how can it be tied in. So they're not all out there, but the ones that are out there are still tied to projects and are still collecting data. And some of those are operating through MCAN2. There are also other coalitions that are out there.
Do we know if do we have any evidence that the gains that were made during the project period, the results that were shown in improvements in all of the outcomes that you mentioned, that they're sustainable over time without the coalitions in place if they run their course?
That's a good question, and I don't have the answer to it. Something to study. I think the last Ally studies that I showed about the system change and policy change, which I think is where you're headed on this question, was actually done at the end of Allies and continued for 2 years after Allies programs were completed. So there's a short-term, longer-term follow-up, but now 5-6 years later, I'm not sure. So the Benedict, LaChance Benedict article that I talked about is the one that really focused on that. So there was some continued policy change. I expect that policy changes have been affected in the other communities and are still there. We don't have the capacity to go study it again. Claudine?
No, in fact, I had the same question as Brian, more related to sustainability and what was happening now. And if we see now, is there, now that there is much more awareness, in fact, of the causes of asthma in children and all this work that has been done by these coalitions, is there, do you think there is a decrease in the incidence of asthma?
No, there's an increase in the incidence of asthma. One of the great important things to say, thank you for getting back to it. What triggers asthma? I didn't mention it before running through fast. What are the biggest things that trigger asthma in cities where the asthma prevalence is highest? Dust, mites, roaches, rodents, molds, environmental tobacco smoke, toxins, things like that, right? Furry animals. I did work in homes on this stuff. How much can I change that from a provider standpoint? Okay? That stuff's still going on. So until we get it, so when people talk about the social and behavioral determinants of health, that's reality. And how we need to think about broad-based and different approaches to get at those things. That's what we're talking about. If we try to do it alone from a health system standpoint, from a provider's office, good luck, you'll never get there. So at the same time that we've had improved asthma medications and a better knowledge of this for 25 years of how to apply those asthma medications, and by now at least we've done good provider education, we have a whole new generation of providers that understand this and are doing this, right? We've got all these medical improvements, and we're doing worse in the incidence of asthma, and about as badly, maybe a little bit better in the control of those that we identify. But there's still a lot of people out there that we don't identify. So until we get to all those other factors, we're not going to change the incidence a whole lot. So back to Brian's question, which is a good one. The system changes that were put in policy. Now, I know Long Beach, California changed stuff about idling truck engines in neighborhoods. That's still in effect. So a lot of the policy system changes have happened, and hopefully they're developing, and hopefully we'll do better as we get into the Delaware state model for Delaware, but across the country, other models. So I think that a lot of that stuff is being maintained. We're just not able to measure it in answer to Brian's question. But I think so, at least some of the system changes are still going on, and people involved are still doing this work. It's how can we take the next step, I think, is really important.
Question. We have one more question over here.
Yes.
Is the CareLink line still active?
CareLink.
No, that was active until about 2-3 years ago. And that was through the second round of funding and the infrastructure support. When it went to MCAN 2, the funding mode changed, and it went more to a focus on what I was just talking about with the CAP program and an asthma navigator working across the community with community health workers and working to get people to care. So the health workers go into the homes, they do things like vacuums and cover pillows, and if you have a lot of dust or if you have people that smoke, you try to ameliorate the dust. If you have people that smoke, you ask them to step out of the house. So there's local care, and then there's tying to people to care. And when they go back home, the home navigators or health workers can help them adhere to the medications better, set up schedules, understand the barriers to care in the home. So there's a lot of coordination that's happening, and that's what's happening in MCAN 2. The link line is not further supported, but the other side of that is, as I mentioned earlier, those types of programs have now been incorporated into both health systems and insurance programs, so that model is maintained depending on where you are. Is it being done for childhood asthma or not? The answer is in some places it is, but not every place. Do I think it's a good model? Yes, I do. And, the other thing about the Finley article that I went through, that was about evaluating community health worker models predominantly and school-based education models, not provider models. So that article, you check back on the slides, which will be circulating, that Sally led and I was second on, is about the locus of support for people doesn't have to be in the practice. And this came up in a discussion I was in just a few days ago. Do community health workers come from the practice? The answer is sometimes yes, but there's a public health model, and then there's telephone care coordination model. And how do we apply them differently? I think one of the lessons to be learned and understood from this is that it has to be locally adaptable and implementable, and the coalition or the folks around the table, whoever they are, whether they're an official coalition or not, can help you figure out how to do it in their practices, in their homes, in their communities. And if we can hear them, that's about the patient and family-centered stuff, right? If we can hear what they need, if we can collect that information, we can define a better intervention, and then from a research side in Excel, we can study. So it's about that input and understanding what needs to be done locally, either in the home or in the community, and how to apply that. And if we can do that, we can be successful. So it's an optimistic note. We're a few minutes after 1. I'd love to talk more, but perhaps another time we'll come back for more of this kind of stuff. I really enjoyed doing it today. Thank you for everybody
Thank you.
in the room and listening. And have a great day.